Good evening friends. Today we are going to discuss about the INI-CET July 2021 session. We are going to talk about all the radiology MCQs that were asked in the exam. The main thing is why we are going along with this presentation is I am presenting you all the authentic MCQs, along with them the authoritative answers. This thing is a worked format. Right now the thing is it is first in India. What we have to observe is I have heard through the speed students that there is a lot of discussion that is going on in all the online platform, which had added to lot of recall sessions and which had added to lot of confusions in them. So here I am presenting you all the questions that have been asked in the exam, which are authentic, because we have taken a lot of time in analyzing what questions have been asked in a logical manner and what is the authoritative answer from our side. It is a worked format. There is no area for discussion. I have presented you all the questions that have been asked in the exam along with the appropriate options, and let's begin it. And myself is Dr.A.Aditya Vardhan. I have done my MBBS from Government Madras Medical College, and right now I am doing my MD in radio diagnosis. Okay, so why this discussion is there are a lot of discussions that have happened in the online media regarding the questions that have been asked in INI-CET PG 2021 that happened on 22 July 2021, which had added to a lot of confusions. So here the main objective is there is no incomplete recall in our session, no vague discussion we are going to do, and no confusions, by the way. These MCQs have been collected from authentic sources, social media platforms, and from our speed students who've been our backbone in compiling these MCQs. The main thing is my friend, my close friend, also gave the exam this year, INI-CET PG 2021. He was a main support in gathering all the MCQs. He clarified a lot of controversies regarding these MCQs. And the next important thing is, in speed, our surgery team as well as the radiology team, we have taken a dual approach in discussing the MCQs, because after every discussion there is going to be a confusion or controversies. We have taken a dual approach so that at the end of this session, the aspirants who are going to listen to our sessions are going to get benefited from this. We have avoided most of the controversies, by the way. It is 90% to 100% the authentic. And important thing is I wanted to say that fortune favors the brave. So by the way, what I am coming to say is this exam, INI-CET PG, it's about the questions were more in a challengeable way. They were not as difficult as the past JIPMER papers, past NIMHANS paper. They were more like a typical AIMS pattern with a clinical tinge in the middle, and no as much of depth like a PJIMER paper. If you have gone aggressive in this paper, you would have done a great job. Let's start with our first question. You are an intern working in a hospital who has to identify the scan given below. There are 4 options given for this: CT scan, contrast dye study, MRI scan, and a radiography scan. From these 4 options, I can come to a conclusion that it can't be a radiography image, because radiography in radiology means it's X-ray, the images which are taken with the help of X-ray, and it can have to the maximum 3 images like chest AP view, PA view, chest lateral view, chest lateral decubitus view, like that. But here you see we have got 3, 6, 9, 12 images. So as from your point of view, what I can see is it can be either a CT scan or a MRI scan. So what is this contrast dye study? This contrast dye studies, dye means it is using fluoroscopy. So using fluoroscopy, whatever study we do is called a contrast dye study. So like MCU, AGU, like that. So this is also not an option. Radiography is not an option. Okay. How to differentiate between MRI and CT scan? Basically, this is a very easy question that they have asked in the exam. That's why I came with this question first. You look at the spine part. The spine part here, the vertebral column is white in color. In CT term, it is hyperdense. Hence, the answer is CT scan. It's a very easy question, friends. So here, the bone is white, that is hyperdense CT scan, and the dye study which we talked about is used in X-rays, radiography, which is a fluoroscopic study using contrast. Okay, so it's clear. The analysis of this question, the question DNA is, it's a very easy question. The thing is, during the exam you should not get yourself like in INI-CET exams they ask us very difficult question, hence it must be something which is above our level and mark something else. This is a pure simple question, easy question, CT scan. This question should not be mistaken. Let's go to the next question. The question is, identify the structure marked in the given CT image. Here the main thing what we have to understand is, what they have asked us after a discussion with a lot of aspirants, I came to know is, they have marked this area and they have asked what is the structure. So the four options are anterior ethmoidal air canal, posterior ethmoidal air canal, cribriform plate of ethmoid bone and optic nerve. I will help you crack this question without the image itself. First thing, cribriform plate of ethmoid bone. This is a bone, hence it will appear white, hyperdense in CT. And anterior ethmoidal air canal, posterior ethmoidal air canal, both are going to be hypodense. So that is what we have to crack here. Optic nerve is going to be inside the orbit part, and this is the optic nerve. But what they have asked is this point, and it is going to be either of first option or second option. I will tell you how to crack it. See, look at the image carefully. You should know little anatomy regarding this. The first thing is, you can look at this is the nasal part, intranasal, this is the orbit part, and this is the maxillary sinus. Okay. So what they have done is, basically, if you look from this view, they have taken the scan as it, so that you are able to cover this part of it, and it is in the anterior part. So in the anterior part, there is going to be anterior ethmoidal air canal. So posterior ethmoidal air canal is removed based upon location. Cribriform plate of ethmoid bone based upon the radio density, that is hyperdense in this case, and optic nerve is also based upon location. Hence we come to the answer, anterior ethmoidal air canal, which will have ethmoidal artery, which is a clinical significance. Basically, how we have cracked this question is, we have cracked this question based upon the location and about the density, whether it is hypodense or hyperdense. These are the 2 points, and it is also a easy question which they have asked in the exam. Okay, let's go to the question next. What is the preferred modality for localization of primary hyperparathyroidism? Look at this question, preferred modality for localization. So the 4 options are Sesame B scan, CT scan, MRI scan, FDG PET scan. I have straight away given the answer. It is not about discussing and making you more stressed about what will be the answer. It's a worked format. So you have all the answers. I am going to tell you how to come to the correct answer, how to eliminate the other options which are wrong. So basically, Sesame B scan can also be given as technetium Sesame B scan, and the best appropriate way is Sesame B SPECT scan is what they should have been given. And this is a potential area for future MCQs. I will discuss with you. Okay. So what are the modalities that are available for localization of primary hyperparathyroidism, parathyroid adenoma are? The first thing which is the latest modality is 4-dimensional CT scan, also called 4D CT. Next best option is fluorocholine PET scan. And the third, which we are doing regularly, is Sestamibi SPECT scan, which is a nuclear medicine scan. Okay, now I will discuss with you future questions. Okay. Let's say, what is this 4-dimensional CT scan? The 4 dimensions are X, Y, Z, X axis, Y axis, Z axis, followed by the 4th dimension, which is time. Same like Marvel movies, we are entering into the 4th dimension. Okay, so how to differentiate is, see how this modality is overtaking Sestamibi SPECT scan is, let's say you have a lesion in the anterior aspect of the neck. That can be, okay, see why we are doing this modality, because our interest is parathyroid gland, looking for a primary hyperparathyroidism or parathyroid adenoma. So let's have parathyroid. So it can be a parathyroid lesion, and what is present on the anterior aspect of the neck, which we all know, is thyroid gland. Then there can be vascular structures, which can be an artery or a vein, and there can be lymph nodes. These are the 4 structures of interest present in the anterior aspect of the neck. Here, how to differentiate using 4D CT scanners? Look at it carefully. This is very important. I feel that this question or this thing which I am discussing right now will appear in the future INI-CET exam that is going to be conducted in the November month, which should have happen, or in the next year. Look at it. When we are going to do a non-contrast CT scan, followed by that we are going to give contrast, which is in the arterial phase as well as the venous phase. How will the parathyroid lesion will enhance is, they are going to be in non-contrast CT scan, they will be enhancing, and in the arterial phase they are going to enhance. In the venous phase there will be absolute washout. So how will be a thyroid lesion? They are going to appear hyperdense. Okay, so first thing is, why they will appear hyperdense is, see, thyroid gland have lot of iodine in it. That iodine itself is like a contrast, hence they will appear hyperdense. That is how you will differentiate a thyroid lesion, a thyroid nodule, from a parathyroid lesion. First thing. Next we are coming to vascular aspect, that is artery and vein. Arteries and vein, they will be in arterial phase, they will be enhancing. In venous phase it will remain white. This is how you will differentiate vascular lesion. And the lymph nodes, they normally appear hypodense on non-contrast CT scan, also in arterial and venous phase. So with this you will be able to differentiate the 4 lesions: parathyroid, thyroid, vascular and lymph nodes. I don't feel you will have a doubt in this, but make sure you go through this, because it is a future potential MCQs which I feel will come in the next exam. Okay, to the next question. In the current scenario, what is the gold standard for diagnosis of myocarditis? The options given are MRI magnetic resonance imaging, endomyocardial biopsy, brain natriuretic peptide or B-type natriuretic peptide, echocardiography. I have also added the E option, that is D-dimer, domain dimer, because I feel that some of the students were very much in discussion that this option was also there and BNP was also there. Hence I wanted to make sure that all of the students get cleared of this controversial question. And the answer is MRI. Even appropriate, the given answer should be contrast enhanced MRI, which is called CE-MRI summary. I will discuss with you how we come to a diagnosis. The main thing what you have to look out in this question is, current scenario. For this you have to understand that the words like this make a major change in the answer. and what is the gold standard for diagnosis of myocarditis. Let's eliminate one by one option. So more often, what is considered gold standard? How we say what is gold standard is? Gold standard means it must be a diagnostic test plus it must be a therapeutic test. If it does both of this, we call it a gold standard. Example, we can say ERCP, digital subtraction angiography. It must be a diagnostic test. I will better explain to you. Gold standard test is, it must be a diagnostic test plus a therapeutic. It must do both of this function. In this case, we can say example like ERCP, endoscopic retrograde cholangiopancreatography, and digital subtraction angiography. Or it might be a digital diagnostic test plus it should give us a biopsy sample. So let's look at it. Here you can come to a diagnosis that endomyocardial biopsy can be an answer, but I won't go with BNP, which have to be done in the later stage, not echo, not domain dimer. I have confusion that it can be MRI or endomyocardial biopsy. So how to proceed further? Gold standard test can be diagnostic plus therapeutic, example ERCP, digital subtraction angiography, or it can be a diagnostic plus pathological specimen giving test like biopsy. If the question was best non-invasive test for the myocarditis, I will go with MRI, that is contrast enhanced MRI. Best invasive test for the same biopsy for the myocarditis is endomyocardial biopsy. So it's clear now, students. If it is best non-invasive test, it is gonna be contrast enhanced MRI. Best invasive test is going to be endomyocardial biopsy. But in the current scenario, if they have given in the present scenario, presently, what is the gold standard investigation of choice? The answer is contrast enhanced MRI. Anyway, the ultimate gold standard will be biopsy. But just imagine whether we are going to do biopsy for all the patients who are presenting with myocarditis. It is not the case. So here the best option will be contrast enhanced MRI. So what the take home point is, try to observe why a specific word is given in the exam, because it makes a huge difference between the things, and proper frame of mind and reading between lines will make you get the answer correct. So it's a little tricky question. If you have neglected the word in the present scenario, you will be marking endomyocardial biopsy. But if you have read it properly and you are in a proper frame of mind, which makes a huge difference, the answer will be MRI. That would be the answer. Next question. Okay. Identify the MRI sequence. Okay. Let's look at the options. They have given proton density, which can also be called as PDFS, susceptibility weighted imaging SWI, apparent diffusion coefficient image ADC, and FLAIR, which is called fluid attenuated inversion recovery image. See, you look at the image, many of the students were saying that it can also, they have given option like gradient echo. That leads to a lot of confusion, because see, susceptibility weighted imaging as well as gradient echo, they are very synonymous with each other. And when you look at this image, you will come to understand that this is done in the case of, we in radiology do SWI image or gradient echo whenever we suspect microbleeds or calcifications in it. Okay, so this is the image, and the answer here is, for this controversial question, susceptibility weighted imaging. Gradient echo cannot be another option because both are synonymous with each other. Let's go to the next question. So this is a very nice question. I like to say to you because we discuss this question a lot, and most of you are well aware of this question. Let's see how tricky they have gone, because the exam is INI-CET PG, no? They are little tricky here. A 65-year-old male patient presented to the casualty with left-sided hemiparesis and aphasia. His BP was 160/110 mm of mercury. His blood sugar was 160 milligram deciliter. Non-contrast CT was done, which is normal. No diffuse axonal injury suspected. What is next step in the management of the patient? Let's look at the options. MRI to see ischemic zones, CT angio to rule out large vessel occlusion, tablet labetalol 10 milligram, arterial blood gas analysis. Okay, see, the main thing is I am going to approach each and every question as if I am sitting next to you. I am of the same mindset like you aspirants, so that you will have a better understanding of what I am coming to say. In this question, they have asked about what is next step in the management of the patient. Hence, 65-year-old male, not going to make any difference. Left-sided hemiparesis, no difference it is going to make. Aphasia, no difference. His BP was 160/110, has an impact, I will tell you. His blood sugar was 160 milligram deciliter, no change. NC-CT was normal, it has an impact. And many of the students were saying this line was given, it makes a huge difference. No diffuse axonal injury suspected. What is next step? From this question, what and all I can do is, first I can eliminate arterial blood gas analysis. Why? Because it is not the next step in the management. We are going to do that once we have recovered the patient. And tablet labetalol 10 milligram, what does it imply? See, according to Harrison 2021 edition, what they have discussed is, if the blood pressure is more than 185/110 mm of mercury, we are supposed to give tablet labetalol 10 milligram stat. Hence, here it is 160/110. So, this is not the next step. Now we are left with two modalities, that is radiology modality. Here look at non-contrast CT was normal. So, and no diffuse axonal injury suspected. Whenever a patient comes with stroke, we have two things like that, the stroke protocol, what we do. In the stroke protocol, first of all we deal with non-contrast CT scan, that is mainly to find whether hemorrhage is present or not, to rule out hemorrhage. Here NC-CT is supposed to be normal, and that line no diffuse axonal injury suspected helps us remove MRI to see ischemic zone is removed. We come to a diagnosis CT angio to rule out large vessel occlusion. Okay, sir, how you are saying CT angio, what is the role in it? I will discuss you very clearly. Stroke is like focal or global neurological deficit of rapid onset, mainly due to vascular cause. This is what is given in McLeod. Okay, we first perform NC-CT scan to rule out hemorrhage. If the patient is within the window period, in this case, a window period for stroke will be like 2 hours, less than 2 hours, we will try IV intravenous tissue plasminogen activator. And since the patient do not have diffuse axonal injury, we no need MRI sequences to further proceed. The two options which are left in this patients are mechanical thrombectomy and intra-arterial thrombolysis. We can only do this if we have confirmed large vessel disease. Okay, so in this patient, we have to confirm whether the patient has large vessel disease. If the patient has large vessel occlusion, then we can proceed with these two things, mechanical thrombectomy and intra-arterial thrombolysis. To confirm large vessel disease, we should do CT angiogram. And how to eliminate tablet labetalol is 10 mg start only if BP more than 185/110 mm Hg. So in this case no need. And ABG analysis is not a next step, we can do it after recovery of the patient. Understand students? Here each and every option I have eliminated for you and this is the answer, which is the right answer. This is part of the previous question, that is susceptibility weighted image. We use for mainly hemorrhage and bleed and diffuse axonal injury. They can even twist the options like, see, susceptibility weighted imaging is also called gradient echo, GRE sequence, also T2 star. If you see a T2 star, it is equal to SWI and GRE. Clear? Next question. My favorite question, led to a lot of controversies in the last 3 to 4 days. It's like literally two group of students are fighting each other. Like this is the answer, that is the answer. I have simplified it a lot for you. You take home all the information. Anyway, with this information, the next step in the NEET exam, which is about to come on September 11, 2021, exactly 47 days or more, you go through this, anyway you will crack this question if it repeats. I have made sure all the information I have shared with you. Okay, let's go to the question. From your point of view, see, a 35-year-old female is found to have a renal mass, Bosniak type 3. On ultrasound examination, CT of the patient is done and shown below. What is the most likely diagnosis? Students, observe here, a 35-year-old female is not much impact in this case. Found to have a renal mass, good. Bosniak type 3. This makes a significant impact in this question. CT of the patient is done and shown below. What is the most likely diagnosis? The options are angiomyolipoma, renal cyst, renal cell carcinoma, renal oncocytoma. Basically, what and all is tested at your level is angiomyolipoma. I make sure speech students will not make mistake in this because we have discussed it a numerous number of times. And renal oncocytoma also you would have differentiated. But why this question has been such a controversy is because you are doubtful about whether it's a simple renal cyst, because very simple and normal things in radiology is very difficult, and renal cell carcinoma. Okay, the answer after a great discussion is renal cell carcinoma. What extra point I want to add is it is a predominantly cystic type of renal cell carcinoma. That's why INI-CET have used the word Bosniak type 3 on ultrasound examination. Let's discuss it further for the upcoming future exams. See, Bosniak classification was used for renal cyst from 1996 for evaluation of renal cyst. So here what is the thing is, the type 3 cyst is a complex solid cystic cyst. Type 4, if a cyst is Bosniak type 4, it is going to be 100% renal cell carcinoma. Since they have used the word type 3, it is going to be complex solid cystic cyst. I have also added the Bosniak renal cyst classification system. Make sure you go through it at least once. Let's discuss it. It's going to be very interesting. See, first what I have made is, I will go through along with you. This is a CT scan image. It is a axial section and is a non-contrast CT image. Look at the kidney. This is the kidney part. In the kidney part, you are able to make out a big. If the presentation is like this, it is a renal simple cyst, Bosniak type 1. Let's go to this image. Same axial section, CT scan, CT abdomen. Here, this is the kidney part. Just differentiate between these two. Here you are able to see a heterogeneous lesion. It's a heterogeneous enhancing lesion. That is going to be a renal cell carcinoma, most common malignancy in a renal cyst. If a patient has a renal cyst, what is the most common malignancy that is you are going to be afraid of is renal cell carcinoma. And if it had a solid nodule in it, it is 100% RCC until proven otherwise. You should understand it clearly. Then we are going towards renal oncocytoma. Students, you never used to make mistakes in this, because my opinion is that you will be very strong in those classical signs and appearances. See, renal oncocytoma will have a central scar, a stellate scar, spoke wheel appearance. central scar, stellate scar, spoke wheel appearance. Look at this, this is the kidney part and this is the lesion having a central scar, stellate scar, spoke wheel appearance. In my classes I used to bring out visual effects so that those lesions you will never forget, and that's why when we were discussing post exam, if it is a renal oncocytoma, you would have definitely told me that it is renal oncocytoma, or if it is a angiomyolipoma, you would have definitely said it. Hence I come to a logical conclusion that it will be most likely, since it's a Bosniak type 3, it is gonna be renal cell carcinoma. Renal angiomyolipoma, it is a fat containing structure. Okay, how sir you are saying this is a fat containing structure is, for the other students understand, this is the subcutaneous fat. Look at the color, it is black, which is hypodense. Look inside, this is the kidney part and it is black in appearance. Compare it, both are same, hence it is fat density. Another thing, what trick we use is, we keep on this area and measure the Hounsfield unit. It is going to be minus 10 HU to minus 30 HU Hounsfield units. That is how we will differentiate. Most probably an average student will never make mistake on renal angiomyolipoma or oncocytoma. The confusion lands here, renal cell carcinoma. That's why it's all about a renal cell carcinoma. Predominantly what I will say is a cystic type of lesion. Okay students, I felt you have got clearance in this. The answer is renal cell carcinoma. Okay, look at this. Next question, 5-year-old child presented with mild abdominal discomfort with intermittent abdominal pain. There is no other symptom. Radiograph was given below. What is the most likely diagnosis? Let's look at the option. I am just viewing from your point of view. Morgagni hernia, 2 hernia they have given. Oh my god, it's gonna be little confusion. Gastric volvulus, we have heard a lot about sigmoid volvulus, cecal volvulus, coffee bean shaped appearance. Oh my god, what is this gastric volvulus? Let's see. Diaphragmatic eventration. So 4 options they have given. First thing, as we have discussed in our class, speed classes, Morgagni hernia, always see, Morgagni hernia is going to be on the anterior aspect. Bogdalek hernia is going to be, we say BPL, Bogdalek posterolateral aspect. Gastric volvulus and diaphragmatic eventration. These are the 2 options which are left. Okay, let's look at this students. See, the main thing what you are seeing here is, this is a chest x-ray, regular view, PA view. You are able to see a big lesion present in the thoracic cavity. It can be all the 4 options, but I will decode and eliminate one by one option. 5-year-old child is not going to make a big difference. Mild abdominal discomfort, first 3 options can have this. Intermittent abdominal pain. So this is the word which I want you to look at very carefully. Intermittent, it occurs intermittently. Whenever the patient had something, it's like on and off. Hence I come to a diagnosis that it is a most commonly gastric volvulus. Many students had controversy regarding this question, like the image was different or like, but majority of the students were like, this was the image which is given below. Okay, how to identify, we'll discuss further ahead. See student, whenever in a chest x-ray you are able to see such an image which has colonic loop inside it. Colonic loops will have the hostrations, things like that. That hostration, hostral markings, it is a Morgagni hernia. And why Morgagni hernia? It is on the anterior aspect, right side. And Bogdalek hernia will be on the left posterolateral. Since it is present on the left posterolateral, I did not present it with an image, that's it. And gastric volvulus is like a rolling type of hernia that results in a rolling type of hernia which got twisted, that results in gastric volvulus. Results in a center large loop lesion with air fluid levels. Okay, and why sir, why it is not diaphragmatic eventration? Understand it students, diaphragmatic eventration is is like the last choice. If we eliminate everything, we come to this diaphragmatic eventration. The diaphragm will be elevated in this case. Look at this image. See, normally the diaphragm should have been here, but here the diaphragm, a thin layer of diaphragm has gone so high because of its weakness, and gastric fundus shadow is here. So from these images you can understand that the question they have asked is all about gastric volvulus. All questions in radiology we can have a debate about it. Lot of controversies are there, but what I have done is I have come to a logical conclusion of what the question might be and what the 4 options might be and what the correct answer might be. Let's go to the next question. Unicornuate uterus can be identified by which of the following investigations? Laparoscopy, HSG, X-ray, hysterosalpingography, X-ray, and phalloscopy. It's like a little tricky question. I'll come to that later, but seen from a point of view, student's point of view, look at it. Unicornuate uterus can be identified by which of the following investigation? Laparoscopy. Okay, by doing a laparoscopy we can identify it, sure. Hysterosalpingography, yeah, this is also answered because we are viewing uterus and fallopian tube. X-ray, X-ray is not an answer because X-ray is limited by, it is not able to differentiate soft tissues, hence X-ray is eliminated. But what sir, what is this phalloscopy? Phallo means fallopian tube, scopy is a technique to visualize fallopian tube. This is somewhat you can be able to identify, but the lucky part in this question is it has been a multiple right options, then the combinations they are presented which they are converted into a single best answer. Hence look at it, A and B are correct. If the question in the options they have given A, B and D are correct, I would have asked you all to mark A, B and D. Understand? This can happen in the future. Okay, this is for your easy understandability I have presented it. Laparoscopy, hysterosalpingography, also phalloscopy. All 3 can be used to visualize the unicornuate uterus. Look friends, this is a normal uterus. Okay, this is the fallopian tube both sides and this is the ovary. But here look at it, what has happened? Unicornua, one side cornua is absent. Hence this is what unicornuate uterus is, and for this through which and all modality we can identify or visualize it is all the 3 options which I have given above. And this controversy is solved. Next go to another question. Every question in radiology had been a controversy. Let's crack it. Antenatal ultrasound of a 19-week pregnant female is given below. Identify the likely congenital abnormality. What are the options? Anencephaly. Anencephaly means cephaly related to cranium. Omphalocele related to GIT. Encephalocele, this is related to cranium part. Cystic hygroma, again neck part. Okay, the answer to this question is anencephaly. I will explain you how. See, here we are having the probe, the ultrasound probe, and when we keep it in a sagittal view we get such a image. In this image friends, what and all you can identify is, let's say this is the head part, this is the stomach part, we are visualizing the spine and we are able to see 2 hyperdensity. One is the mandible part, another is the hard palate part. So where is the abnormality? We are not able to see a very white structure in the cranium part. Hence I come to a diagnosis, it is anencephaly. Many people, there was a huge discussion regarding this. Why sir, this is not omphalocele? See friends, the thing is here it is uniformly enlarged, it is not bulging like this. Hence I remove omphalocele from it. Also encephalocele is not there. There is no like through a point everything has herniated out. Not a cystic hygroma. I'll come to you in a minute discussion. I'm going to discuss everything. You are able to see the hard palate, the mandible, no skull vault, which should be white in appearance. Since we come to anencephaly, the main thing is in anencephaly the main appearance is when you see in the coronal view. I talked about sagittal view. When you see in an axial or coronal view in case of ultrasound, both are same. You will see the orbits popping out, which we call as the frog eye appearance. It can also be called the Mickey Mouse appearance, but frog eye appearance is commonly used. Okay, what happens and what is the mechanism here is, see, this fetus lacks the crania. What is lack of crania? Acrania. Okay, understood? Next, what happens if there is no crania to protect the brain parenchyma and the underlying structures? All the brain part will get leaked into the amniotic fluid, which progress to the next condition, exencephaly. Many people would not have been aware of it. Exencephaly. And since the contents get absorbed by the amniotic fluid, you will see no crania as well as the brain parenchyma content, which is called acrania plus exencephaly, anencephaly. The next thing here is, look at this diagram. See, this is absence of crania, hence I come to a conclusion that it is anencephaly. Here I have presented you the abnormal bulge, a well-defined bulge present in the GIT. So it's very abnormal, right? Here is the abdomen part, here is the bulge. This is a classical image of omphalocele, well defined. Next, gastroschisis. See, I presented you this image, look at it. In gastroschisis, you are able to see the abnormal bowel contents which are protruding out. It is not well defined, right? If it is well defined, it is omphalocele. If it is not well defined, you could say that it is gastroschisis. It will be no well defined sac, a focal herniation of bowel loops. And the other option was cystic hygroma. Look at it carefully. In the posterolateral aspect of the neck, you will see a cystic dilatation of the lymphatic system, which is called cystic hygroma. These three are not the option. This is the answer, anencephaly. So you right now you understand clearly why you have come to anencephaly. Sure. This is going to be a little tricky question. Let's crack it. Okay. 17-year-old male patient presented with a cough, hemoptysis since 10 days. Chest X-ray shows a right lung field lesion this side with ipsilateral trachea deviation. What is the next line of management? Students, this question many were not sure about what the image was given. Everyone had a different opinion, but through majority we found out that this was all about a cardiac lesion, in this case rheumatic heart disease, mitral valve stenosis case. Hence we come to a diagnosis that it is echocardiography, since it's a cardiac lesion. Sir, why not, sir, bronchoalveolar lavage? Yeah, we will do bronchoalveolar lavage if it is a bronchial lesion. Understand? So this was not an answer. Thoracotomy and sampling, no. Bronchoscopy, no. The answer is echocardiography. I will discuss with you. Bronchoalveolar lavage, if it is a bronchial lesion, okay, what sort of bronchial lesion, sir? Right middle lobe collapse, if they had given, that would be an answer. But what students were about to say is some haziness around right side, double atrial shadow was there, that carinal whitening was present. It would be a typical case of rheumatic heart disease, so that a cardiac lesion, the answer is echocardiography. Next question, student. Here, look at it. A 45-year-old female having human immunodeficiency virus infection prescribed ergotamine for migraine attack. Developed acute pain in mid-thigh with non-palpable dorsalis pedis. What is the likely cause? If I am what I would have done is very simple. See, ergotamine, I would have marked ergotism. That's all. What, sir? Ergotamine is given for migraine attack. Then what it would be? Ergotism only. That's all. You would have gone to the next question. But what I will do, I will go a step further and differentiate each option for you. The answer is ergotism. Here, what and all it can be is, we could have given the option vasospasm, Saint Anthony's fire, or a Blackfoot disease. Everything could have been given to confuse you a little bit more. My thing is, what I would have done is, I would have, if I would have set the question paper, I would have put like, was given a drug for migraine attack which caused so and so complaints. What is the drug is? It's a nice question. Here they are given ergotamine, hence it's going to be ergotism. Okay. Let's look at the image. See, the image what they have given is, this is the hip part, both legs are given. This is the abdominal aorta undergoing bifurcation into right and left, and here it is entering into the femoral. So this is the superficial femoral branch as well as the distal femoral which is going. Okay, what image it could be? It could be two of the above. Either it can be a CT angio or a MRI angio. MRI angio would have even soft tissue better delineation. Okay. Here the main what has happened here is, the patient has undergone vasoconstriction which has led to vasospasm, hence presented with non-palpable dorsalis pedis artery. It can be a CT angio or MRI angio, abdominal aorta bifurcation. You could see the proximal femoral artery, superficial femoral artery is visualized. But look at it, distal to it, you are not able to see the popliteal artery, dorsalis pedis artery and other arteries. Understood? How to differentiate, sir? See, if the patient had atherosclerosis, look at it, atherosclerosis is not a condition which is limited to a single part. It happens throughout like a systemic condition. Hence, proximal will be normal and distal abnormal cannot be there in case of atherosclerosis. Even the proximal part will have atherosclerotic changes. Okay. Why, sir? Why it is not a compression disc prolapse or polyneuropathy? Like, neuropathic pain can be a possibility, but main thing is, because of ergotamine, we are straight away coming to ergotism. Another take home point is, let's say muscle atrophy. There is a condition, muscle atrophy. These muscles will get atrophied, gastrocnemius and soleus. Here what happens is, there will be just narrowing of the popliteal artery. You will have all white here. Here it won't be white. Here and all you will be able to see white. So if there is a narrowing of only the popliteal artery, this area, we can say muscle atrophy in this case. But this case, typically I can remove atherosclerosis from the option because of ergotamine ergotism, polyneuropathy and compression disc prolapse or radiculopathy cannot be an option. It's like typical because of ergotamine. Students, we have come to the end of our session. What I want to say is, fortune favors the brave. So this exam, INI-CET PG which has happened is it's an exam where you should have taken more aggression, same like this lion. When you step up in this moment of challenge, it powerfully signals to the universe that you are serious about your business and your dreams. Stand strong, you have got this. If you have taken a little bit more aggression, you would have answered more questions. What I say is, from my point of view, out of 200 MCQs, you should have answered at least 180 to 185 plus. You should have gone little aggressive because the exam is not very extreme level or very hi-fi level. They have just dig little depth and they have talked very common things. So you should have gone little bit aggressive in this exam. That's what this is all about. Thank you, friends. work hard in silence and let your success be your roar.